For those of you joining us online, you can also submit questions through the Zoom. But any questions in the audience? So I will actually start us off. So for Dr. George, there seem to be a lot of therapies for ITP now, like second line. So what would push you to use, like what kind of patient factors or characteristics would push you to choose ianalumab? And then the second part of this is like, what other ITP therapies seem to be coming down the line?
Absolutely. I think the way ianalumab, well, the way they structured the trial, and I think it was a very interesting question, was can we get a deep response so that we can get patients onto sort of a time-limited course of a TPO agonist, right? I think most people in this audience would know that once we start a TPO agonist, traditionally we keep them on indefinitely, usually until either the patient or one of us says maybe let's do this small trial of getting them off. But now with ianalumab, you've got a 55% chance of a deep response, right? And so that's tremendous. The other therapies that have been approved, for example, Rilza last year, it's in a second line setting after a TPO agonist, but can be used more frontline. And I think more people are starting to use it in earlier lines, and there are trials for that. There's an anti-CD38 drug, and I'm going to thank you, Lisa, for bringing that up. But as a plug for efgartigimod, we have a trial open here, which is an FcRn inhibitor for patients who are really relapse refractory but respond to IVIG and steroids. So lots of exciting new therapies coming down the line. Lots of it seem to be focused in the more refractory setting, post-TPO. Ianalumab was with a TPO agonist.
I also have a question for Dr. George. As I was mentioning to you before, I think that these meetings are great for those of us who are very subspecialized, because not doing classical hematology, I was unaware that it was interesting targeting BAFF-R for ITP. And BAFF-R is a target of major interest also in malignant hematology for B-cell lymphoma. So this year there were data at ASH from Elizabeth Badia City of Hope showing the targeting BAFF-R with a CAR-T was highly effective for mantle cell lymphoma and aggressive lymphoma. But one concern is that as BAFF-R is a receptor expressed very early in the ontogenesis of B-cell lymphocytes, that this may translate into very prolonged B-cell aplasia, very severe hypogammaglobulinemia. So can you comment more whether in this study you have to follow regularly IgG levels? Did you have to give proactively IVIG? How was the B-cell aplasia dynamic overall?
Absolutely, yeah. So at least in this trial, we did follow immunoglobulin levels, and you're supposed to, as long as the patient's for extended follow-up. At least in this one, there was only one patient, and that in the 9 milligram per kilogram group that had prolonged hypogammaglobulinemia. So seems to be well tolerated. Again, it's skewed a little younger. Most of the patients are 65 and younger. And I know there's a phase 2 coming down to look at tolerability. So I think we'll have more mature data in the next year or two regarding immunoglobulin levels. But on average, from what I remember, it was IgG levels around 463. No one got prophylactic IVIG, although that was a conversation. Yes.
Question for Christine. So I guess number one, with the FDA, is there any barrier or insurance barrier to getting people who are fit onto venetoclax azacitidine? I love your algorithm, but I'm just wondering, is that in practice? I didn't catch, is that actually practical, especially with venetoclax being oral, that you have to get insurance?
It's a great question. So the FDA label for venetoclax for AML has not changed. So it's approved for patients who are 75 and older or who have comorbidities that preclude them receiving intensive induction chemotherapy. And so when we use it for younger patients right now, this would be considered off-label use. Thankfully, as we've been doing this more, we really haven't had issues getting the venetoclax approved for younger patients. I can think of one younger patient, I think in her 30s, who we did have the venetoclax get denied. in the past year, and ultimately we weren't able to get her an outpatient supply of venetoclax. She actually ended up we have it on our hospital formulary. She had to stay in the hospital to get her month of induction, which, time in the hospital ended up not being different than that she would have had with the 7+3, but still kind of less toxic, typically less transfusions, less infections. So I think she still had benefit from it, but she did have to stay in the hospital longer when we weren't able to get it approved through insurance.
And my second question was about the MDS with the use of venetoclax. I'm a little bit dense and this is new to me, but I don't know what's going really on with that. Do you see a future what do you see in the future of venetoclax and MDS? Is that part of the treatment?
It's interesting. So, it was disappointing when the overall Verona study was negative, but we've all treated, we've been treating our higher risk MDS patients with increased blasts, with Ven/Aza kind of again off label, for several years now, if they're not on a trial. And we've all seen how quickly you can see responses, how well counts can recover. I think the issue is that in the Verona study, it was this very elderly population. Most of those patients did not go on to stem cell transplant, which is what people with higher risk MDS really need. And so I'd say for sure for patients where the goal is to have a transplant quickly, if you want the blast less than 5% pre-transplant, which is our goal here, but is not uniform at all institutions, then you can get there much faster with Ven/Aza than if you're doing kind of a single agent hypomethylating agent, which can take up to 4 to 6 cycles to see a response, and then sometimes have to add the venetoclax later on. So there's definitely a future. And then there's also a lot of other kind of ongoing MDS trials that, could also change the future of standard of care. I don't see single agent HMA being the standard of care forever. Hopefully not, although there have been a lot of high profile negative trials, but still kind of a role for combinations there.
So my last part of the question was, what about the NCCN guidelines? What do they say about these issues compared to the FDA off-label?
That's a good question. So NCCN is kind of catching up, and they do mention the HMA-Ven now as an option for the higher risk MDS patients. I actually don't recall what it says now for AML, if it's in there yet or not, but I think they do seem to get there faster than the FDA does for sure.
Thanks.
Okay, one more question for Dr. McMahon. For the younger fit patients who could potentially get the Aza/Ven, can they get their treatments completely outpatient?
If you can get their outpatient supply of venetoclax efficiently, then potentially. We've historically tended to admit our patients starting Ven/Aza due to risk of tumor lysis, closer monitoring, and because we have an inpatient formulary, we can start it more efficiently than waiting for an outpatient approval. But for sure, for patients who are low risk for tumor lysis, so for people who don't have really proliferative disease, definitely safe to start outpatient with appropriate monitoring. And yes, it is possible they could be treated fully outpatient for their initial induction.
And then one last question for Dr. George. With mitapivat, what, side effects are you most worried about in these patients, and what patient population are you planning on starting this drug in?
I'll do the second question first. Hemoglobin less than 10. It's approved for both transfusion and non-transfusion dependent thalassemia, but the label's strict in terms of the hemoglobin start. And it has a REMS program due to a few issues with LFTs. So you have to check LFTs every month and make sure it's not elevated before the next prescription goes in. It's just been approved. So I think we're still working through the kinks in terms of getting it into patients' hands.
Okay, great. We will take our first break, and then we will start again for our special guest speaker at 9:45.